main couple of things we do when we first see patients with heel pain is ask questions about when and where is it hurt and how often and the timing and the severity of the pain and those types of things. And I think probably what most people are concerned about is how do I get better, right? Because sometimes this thing can last forever and ever. So you'll see here just a couple of the things that you can see. Probably the most common one is the big words in the first bullet point there, which just mean hurting after you sit down for a while and then stand up. Out of bed in the morning, out of the car after a ride, or sitting down watching TV, getting up, get a glass of water and going to the restroom, and you have that pain that becomes more of an adjutant. And slowly, each time you stand up is another micro injury, so it tends to escalate and get worse and worse. Symptomatically, everybody's a little bit different. Some can radiate, some can burn, some can have usually more sharp abrupt pain under the heel, others are low and dull. And again, it's all part of the examination and palpation. You see all this stuff in the first. So I'm going to kind of keep skipping along. We always do x-rays with heel pain, not because of heel spurs or enthesopathy or things that we know as big words. It just means spurs in the heel or spurs in the posterior heel. Most of the pain is not caused by the heel spur itself. It's caused by the attachment of the fascia beneath the spur. The muscle actually attaches to the spur level, so at any rate, we do x-rays to make sure you don't have a fracture. Signs or symptoms of a stress fracture, foreign body, bone cyst, bone mass, lesion, call it what you will, anything like that. Joint arthritis, any of the other above, even though the joint's above it, but subtalar joint pain can give you sometimes some heel pain. So we pretty much do x-rays on everybody. There you go, that's what I was just saying about tarsal tunnel syndrome, bone tumors, foreign bodies, etc. So these are some of what we call differential diagnosis for heel pain. Treatments, most of them are always conservative, okay? Most of them. And it's all about a response. And my standard treatment in most cases, ice, anti-inflammatory meds, tape, stretching, depending on the pain level, sometimes an injection of a steroid. I think I said anti-inflammatory meds, shoe adjustments, shoe changes, and then stretching. So we can do a lot of this at home, pretty straightforward. And if you're unresponsive, kind of the first line of defense in making this feel better, sometimes we'll try a second injection maybe, or if it's completely unresponsive, sometimes we send you over to my buddy Lance over here. He's got the red dot on him now. So we send him as part of some physical therapy. So if we're not getting the appropriate anti-inflammatory effect through all the above, we get it through, in some cases, manual manipulation, ultrasound, E-stim, stretching, and other things that he can do that I don't know about. Okay? Same stuff. That's a pretty good number. I'd say probably 9 out of 10 or better are resolved conservatively. There are very few. I think the percentage is even higher than that. I don't do a lot of heel surgery to resolve this, except for unresponsive cases, obviously. And then you're going to get to the surgical side of this thing. So, in summary, with the conservative side, it's what we just said. And if you're recovering and you're not having an issue, then great. If you're not, we go to this level, which would be a surgical fix. Back up for just a second. In today's world, I didn't add this to the slide, is there are some other regenerative and restorative types of injectables that we can use today. So if you get past the first level or even back to therapy and maybe things aren't responding and it's still thickened and scarred and inflamed, the other substances we use today, one is PRP or platelet-rich plasma, if anybody's heard about that or done any research or reading. It basically is a blood draw. We do a blood draw from your arm or hand. We centrifuge and spin down that vial of blood and take off the top level, the lighter coat or the yellowish coat of platelet plasma, and then re-inject that back into tendon. We can put it pretty much anywhere because it's not going to hurt you. We put it in tendon, we put it in ligament, we put it in joint, you can put it in fascia. So that's another option for treatment. Statistically, I haven't seen that much of an improvement. I see better improvements in tendon right now, but it is still another conservative option prior to surgery. Okay, so we've got more information about PRP if you guys have questions, and there's plenty of stuff on the internet, obviously. Heel spur resections, we're probably not doing that much anymore unless the segment of the spur is really large, or it's multifaceted. In other words, it's three-pronged or two-pronged, or two separate levels, all found radiographically. Extracorporeal shockwave came on a while back. It's kind of disappeared now in the world. It was a very good treatment, non-invasive. It basically was a percussion wave sent through a water medium, like a water balloon that was put on your heel, and it drove an energy force through that like hitting you with a hammer. So you had to be sedated and you rested, and it basically, again, re-injured the fascia to produce a response or an effect that your body would heal itself. Okay? And I'm not seeing that much. I still have some co-residents and friends that are still doing some of the extracorporeal shockwave. But insurance companies that were covering dropped coverage, ones that never covered just said they weren't going to do it. It was considered investigational, but statistically they were in the middle 90s in recovery. So they still wouldn't approve it. And then fasciotomies, which are open or endoscopic. And I may have a picture or two here, so heads up. Incisional approaches, this is all just kind of more advanced stuff. Medial incisions are the most common. We do endoscopic plantar fasciotomies, which is a cannula that I can use an arthroscopic camera with to go into the plantar aspect of the foot on the bottom of the fascia, okay? And you can rotate that camera up and down so you can see dorsal and plantar, you can see up and down to make sure you haven't split the fascia. The reason for that is to obviously make sure you don't cut one side of it and the bottom half still intact. That's probably the most common procedure utilized as an endoscopic method. It's simple. It's a two-stitch approach, small incision to the medial heel. You make a small incision, you put the little cannula in, followed with a camera. A three-step procedure. You feel where the fascia is, you visualize it, you put a hook blade in there, pull it, and it separates the fascia. We separate the medial 2/3, and that's the most common location. Again, the heel spur is not commonly chased after unless, again, it's really large or it's fractured. So there are a lot of times when I go in to do fasciotomies, and I'm not going to go deep to the bone. The reason being is there's a higher incidence of nerve injury. So it's called Baxter's nerve. Nerve runs right under there. You can actually cause some injury to the nerve, which of course will be chronic. We usually do the, to some extent, mild sedation with a tourniquet so we can see without a bloody visual field. This is the same stuff I just went over. So it's called an EPF, probe, et cetera, is passed through here. Same stuff I just told you. Medial 2/3. It's nice because it can be visualized when you get in the right plane. So in trained hands, it can be very successful. Simple interrupted suture for closure, et cetera, and then references. The other, which is an open procedure, is typically a longer incision because we want to visualize the medial band so we can actually retract and see it. So the obvious is then once we see it, we can retract and resect what we need and go after the heel spur as well. So that is, to some extent, a very brief synopsis of plantar fasciitis or heel pain. So we're going to ease along into the next one. And so some of the other two topics we combine kind of as one, and that's a term called hallux valgus or bunion, or hallux rigidus, which is similar to a bunion. It's just on the dorsal side of the first metatarsal joint. And this is a lot of detail, so we're just going to skip through some of it and talk about it. So have you ever heard the term hallux valgus? Bunion? All right, bunion. Everybody's heard of bunion, right? So it's an actual physical anatomic change. So it's the first metatarsal joint, your big toe joint, okay? And it's an angular change. You'll see a few pictures here in a little bit. Angular change of that. So most people just say it's a bunion if it's a bump. Well, that's not actually true. The bump is actually from the first metatarsal moving like the clock on a hand. So it changes the angle between the first and second metatarsals, and it's a slowly progressive change, okay? You can have it when you're a kid. You can have juvenile bunions, and you can have it later in life. You can get it from birth or you can acquire it from an injury. Okay, so again, we'll just kind of skip through some of this stuff. The other term would be hallux limitus, which obviously means a limitation of motion of your hallux, which is your big toe. Pollex is your thumb. And so we measure the angles, and you measure the angles with a bunion and or with hallux rigidus. These angles are all easily remembered, but we just kind of sketch them on x-rays and kind of determine what they are, and then certain pathologies show up at certain angles, believe it or not. Some people don't have it, true, but at any rate, these are some of the other causes of hallux rigidus, okay? Hallux valgus causes are primarily congenital, hereditary. We adopted it, or excuse me, we got it from our mom or dad or grandparents somewhere along the line. And it's not that we inherit it like hair color, it's a function. So it's, you know how you see a kid walking down the road next to their son, they kind of walk the same? The motion of how they inherit that same motion, that flexibility, that inflexibility. And so that's how heredity passes on musculoskeletal issues, right? This one's a little different, and this one's more structural. So bunions are more functional in their change, and hallux rigidus is more structural, meaning the bone actually changes. It produces more bone to stop the limiting motion. And these are all causes, and they're big words. The main radiographic findings, so again, if you come in with a bunion, and trying to determine, you know, so some people say, well, I've got a bunion, and in fact, it may be hallux rigidus. And some people say, I've got this restriction of motion, and it may be caused by a bunion. So that's why they're combined a lot. So we take x-rays, and we look, we see what those angles look like. When we look at them briefly, the angles between the first and second metatarsals, what we call hallux interphalangeus angle, intermetatarsal angle, hallux abductus angle, all these big words to determine what your pathology would coincide with or look like, okay? The other one is joint space. So how big is the joint space? On x-ray, cartilage doesn't show up. It basically shows up as a space between two bones. So cartilage is primarily water. It's not radiograph. You can't see it. And if there's a loss of joint space, then that means arthritis. Some of you guys probably have some of that, right? All right, all of us do to some extent. So these are all things that we see radiographically. So we can see changes in the metatarsal head, enlargement of the bone on the outside of the joint, okay? Bone on top of it. Sometimes we get cysts. Sometimes you break a piece off. You get loose joint mice, we call them. So a piece of bone that floats around the joint. Cartilage damage, osteochondral lesions, you know, sesamoid shifting, all kinds of just radiographic stuff, obviously, we learn. Hallux limitus x-ray. So we see the little cyst on the bottom and a little flare on the top of the x-ray there. A little dorsal impingement and a closure of the joint on the lateral x-ray on this film. And then this is probably more severe arthrosis or arthritis of the joint, where you start to see whitening and a diminished joint space, or a joint that's closed down. You can see next to it, I don't think that's going to show up. You can see next to it the spaces between the toes. If you guys look right here. So these little spaces between the toes and the joint here, here and here. And then that one doesn't have a little gap between it. And so that's indicative of pretty severe arthritis. Okay? We'll talk about that in a minute, because it's part of how we fix the pain in the joint, whether it be hallux limitus or an angular change like hallux valgus or bunion. More pictures. So you heard me say a little while ago, structural versus functional on the right side, and that's typically the differentiation between these two types of conditions. And this is a clinical exam, so if you came in the office, we want to put you through a range of motion. We get radiographs almost every time first to see what the joint looks like, and then put you through a range of motion to see what kind of range of motion you have. And hallux limitus is staged, hallux valgus is not, so bunions are not staged. We just measure them based on their increase in their angles. The classifications here are based on movement. Primarily it's based on the degree of motion of the joint, okay? And we see all the other stuff that kind of continues to change. Treatments, okay? So this goes in line with bunions and hallux rigidus. Treatments consistent with in the initial phases, anti-inflammatory meds and ice bags. Try to diminish the inflammation, reduction of pressure, orthotics, certain types of offloading pads, shoe changes, extra depth shoe gear, steroid injections, sometimes therapy to increase that motion, maybe in coordination with a certain type of injection. Yeah, and so like we said, everything goes from conservative to surgical if it's unresponsive. Now there's a bunch of stuff listed here again, and these are all the procedures that are listed for one diagnosis. You think, good grief. So there are different ways to assess how the joint's functioning or how it's not. You know, in a knee, you just take it out and put a joint in it. These you have to determine where it's happening, why it's functioning that way, and at what level are you going to operate on it. So it gets a little more complex, okay? So you see joint preserving procedures on the left, so we want to save your joint if it's actually good. So in some cases, there could be a 30-year-old male comes in my office that has really bad joint pain that's hallux limitus. And he wants to know why his joint's hurting, and we've tried conservative therapy, and we've iced him and injected him, relieved the symptoms, but it's just not working. And if his bone was one of those other big words we saw on prior films, we can still do certain procedures on the left side because his joint is still okay. His cartilage is still good, and we're trying to save that cartilage so it doesn't progress through those stages to get worse. So we can use some of these procedures on the left-hand side to determine or to reduce or decompress those joint spaces. And then on the right side, joint destructive basically is an implant. You can do an implant or you can do a fusion. And that's what the joint destructive procedures are. So in a nutshell, hallux limitus is more bone and bone related because it's a loss of degrees of motion, and it can be associated with severe arthritis. And these two main kind of structural things, classifications, if you will, between joint salvage and destroying the joint to make you feel better. That sounds kind of oxymoronish, doesn't it? Okay? So those are the two main ones. So you see the far left where the joint space is narrow, okay? And the joint space on the far side is much larger, and that's a decompression procedure. It's a joint salvage procedure there. Hallux valgus, in a sense, going over to bunion, poses, again, a whole different type of scenario. So you can have pain on the medial side of the bunion, which is usually caused bump pain. You can have pain in the joint or pain on the bottom of the joint, which is usually what's called a sesamoid shift. So there are two bones underneath that small joint under your big toe joint, similar to your kneecap. And if your kneecap were to hurt, it hurts when you move it or move it around, so you get patellofemoral dysfunction. The sesamoids can do the same thing. So you can have bunion pain that is in multiple locations, or one location for that matter. The measurements and angles we go through and determine whether there should be treatment or not, right? Conservative versus surgical. And I'll tell you, usually pediatrics, so from nobody in this room at least right now, except for maybe the little guy over there, from a juvenile HIV standpoint, almost all juvenile cases are operated on. And the reason being is because they're going to develop so fast, they're going to live with their entire life, that they're going to have major deforming forces that cause multiple problems by the time they're in their early 20s. So they'll have major crossover toes, et cetera. So there's a lot of middle-aged teenagers, 13, 14, 15. We try to get them to that age where they can tolerate the surgery and get through it. And then there's the other, the non-pediatric, which is us. When we start to see certain signs and symptoms, usually patients come in and say, my bunion hurts, but I don't want surgery. Or my bunion hurts, should I have surgery? Or what should I do? And we just kind of find our way through that pathway together, because not all bunions need to be operated on. They could be conservatively managed. They maybe an injection will knock the pain out for a while. And then there's the surgical option, of course. There are certain few clinical indicators that I will lean over and start to inform you that I think you should consider surgery. That if the bunion starts to cross over the second toe, or the second toe crosses over the big toe, okay? So if it starts to change, a slight lift in the second toe up, or a pressure from the big toe pushing inward under the second toe, that starts to cause pain, pain beneath the second metatarsal, increased intermetatarsal angle, and some other radiographic findings. You say, well, why would I suggest surgery even in a non-operative, in a non-painful scenario? So if I'm not having a lot of pain in that bunion, what makes me a surgical candidate? That's a hard one to ask, because you say, well, my foot doesn't hurt, but it's got a big bunion on it and I have to wear special shoes and some other things. My concern for you guys is, what about lifespan, right? Eventually the pain is going to happen. The question is when. And if you get to a certain component in your life, age, if you get a certain age in your life, the bunion is, like I said, it's going to eventually cause a symptom. And then you may get to a period of time where health changes, bone mineralization changes, you may become osteoporotic, you may have other medical conditions that says, you know what, you can no longer have that procedure done. And then you're stuck with that. And that has happened in the middle 70s. Patients develop cardiac problems and osteoporosis and kidney problems, and they can't, for an elective case, it's not safe. And then they have bone pain. Then they have sesamoid pain. Then they develop an ulceration secondary to a bunion, and we can't do anything about it. And so that's probably one of the more concerns that I have for the middle to that 60, 65-year-old, 70-year-old age group, is that you're healthy, young, active, and doing those things. You got 30, 40 more years of life to do. What is going to happen to that bunion over the next 30 to 40 years? If you're asymptomatic, you can't have that pain. So there are times when I look at patients and say, you really ought to consider having surgery. Had today a 45-year-old lady. And same thing, when should I have it done? There's no rush. It's not a broken bone. We don't have to fix it tomorrow, but you need to start thinking about it, because if she gets 10, 15 more years and some medical conditions change, we can't operate on it. I mean, Nancy can vouch for me that we see people on a regular basis in their 80s and 90s coming in with bunion pain. There's not a whole lot I can do. They've asked, how long you had a bunion? Since I was 40. So you see, the progression changes and it eventually becomes problematic. And then I've got another lady, poor thing, I've known her for, I think she was my first patient. And I told her the first day I met her, I said, we really need to consider fixing this, and she just did not want to. And for the past 5 years, I've seen her probably every 6 or 7 weeks, and she's in severe pain. She doesn't know what to do, and I can't operate on her. So it's a really tough thing. So it's palliative. I got to send her for special shoes and inserts and all that stuff, and she's still complaining. So there is a fine line about when and where. And usually you guys tell me when you want to have the surgery. That's what I kind of rely on. It's talking through it with you guys. So not everybody has to have it right away. It's not a broken bone or a ruptured tendon. That we fix on a regular basis because it needs to be done. But bunions are a hard discussion. So these are hemi implants. They've been around for a long time, probably 50 years, 40 years. Okay, so this is a resurfacing implant. So it's a partial, so we don't do the whole joint. So if you have hallux limitus, for example, which was the other term with a lot of bone joint space, joint limiting motion, you can go in and clean out all the arthritis, decompress the joint through, again, choosing the right procedure, and then put an implant in. The pain goes away. Range of motion comes back. It's really a good option. So here you see this joint is arthritic and subchondral cysting, etc. And here's the little BioPro implant system. It's very effective. Small, oh Lord, you guys ready for this? Okay, I got some bone in here. So there's a joint. You can see the arthritis. If you can't, trust me, it's there. We take the proximal phalanx and we take a little layer off of the joint. Right there. Sizer, measure, that's the temporary. It fits right in there. That's the reamer, implant, joint's in there. See how quickly, and it's easy. You can do it in 15 minutes. It's straightforward. So we clean off the joint surface on this side, hallux limitus, clean the joint surface off, take the arthritic joint off of one side and put a cobalt chromium titanium implant in, and range of motion is then worked on afterwards. Okay, so you see we start to move the toe, and this is, again, well, that's total. This is the more common one that we're using today. Okay, so this is what's called a uni or a hemi implant. The other one is a total, and this is not something, I put it up here for lecture purposes, but I don't like them. Silicone silastics, they can break down. I use them in rare occurrences, rare occasions. If patients have too much bone loss from another procedure, failed prior procedure, and we got to figure out how to get them functional and anatomic again, sometimes this is the only option. And then fusions, that's the last option. Okay? Let's say you had middle to, how old are you, sir? How old are you?
I'm not 80 anymore.
About 80 anymore?
No,
It's your 30th anniversary of your 50th birthday? 81. So you say, well, doc, what would be a procedure that may work great if you came in and you had a stage 4 hallux limitus? That's for me to know. Look at your x-ray and determine how bad your joint looks, right? Maybe it's not a bunion, maybe it's hallux limitus, or maybe it's a bunion and you got terrible arthritis in it. There's another method that you can do that works really effective. And I tell you, in some cases, it's better than offering an implant or a colectomy cleaning procedure or partial implant. And that's a fusion. And again, these fit in the right case, in the right person at the right time. It's not for everybody, okay? And so we see right here where we start talking about arthrodesis. These are stabilization procedures. And this is an old method, an old film. I put it up there because it's a wire sticking out of the toe, okay? Today's world, we use these little small compression screws, and they're even systems for the first metatarsal for fusions, and they work very, very well. That particular procedure is another option for both bunions and hallux rigidus. Okay, we try to keep normal toe function, we really do. But if you failed a prior procedure, it may be your only option to fuse it, because you can't take out one implant and put another in. And so it's hard. If you're choosing the wrong, unfortunately, the wrong procedure. For example, I have a case that we're getting ready to do next week, I think, or the week after. Patient was corrected a bunion with a 2-component joint implant. It's floating around here. So what happened? The implant fractured the bone because you can't fix a bunion with an implant. So stress causes the pain. So now we've got to take the implant out, take bone from her hip, because the space that was taken out by putting the joint in, now I got to put bone in there to put, so you see, so you got to choose the right procedure. And then we got to put a plate on and fuse it, because there's no other option. You can't put an implant in there after that. There's too much bone loss. So again, that's why all these procedures are available, and the reasons for fusions, et cetera, are there. Then you fix the bone inlay graft between the two joints, pull the pins out, and it locks the joint still. Okay, hammer toes. Acquired, right? Drop a brick on your foot, break a bone, rupture a tendon, you develop a hammer toe, right? That's the acquired form. Heredity, function. How we move, how things, right? How things flow. So, mechanics and anatomy, dysfunction, digital deformity, surgical management, soft tissue, and bone. In summary, same thing we just said. I see a lot of this one on the bottom. So if I see calcaneal fractures, which are your heel bone, if it fractures, we see a lot of the hammer toes happen after that. I had a patient operated on Monday from tarsal tunnel, which is a nerve problem. The nerve started to cause atrophy of the muscle that pulls on the toes a little bit. So he had hammer toes. So there are reasons for lots of things. So I had to decompress the nerve to get it to at least stabilize where it is. You see up here, these are nerve disorders. CMTMS, CP, Friedreich's ataxia, et cetera. So neuromuscular disorders. The cause is not fully known, but there are three main thoughts. And the ways are how the flexor and extensor tendons work. So the ones that you see in your hand when you lift like that, you have them in your toes, and the same ones that pull the toes down. Flexor substitution, extensor substitution. But what they do is they affect the small muscles in your foot. If you could do this, that would be the muscles that they affect. You can't do that in your foot. They're stabilizers in the foot, so they keep them from bouncing off the joints. They stabilize the toes and keep them on the joints. Okay, and that's what all these muscles are. Okay, so when we look and assess a hammer toe, two main things. Why is it happening? And then the two main things are, is it flexible? Is your toe flexible? It'd be nice if I had a chart that showed this. I can straighten it manually with my finger. I'll let it go and it curls up, right? So there's a tight rubber band in there. So it's soft tissue. So you can actually lengthen the tendon and the toe straighten. Pretty straightforward. Now, if the bone doesn't reduce and you pull on it, it doesn't move, then it's a bone block. The only thing you can do with bone that's blocking a joint is take the bone out. There are different ways to do that, okay? So the old method was to do arthroplasties, and I don't know if I've got this in there. So the way, again, assessing, you grab the toe and straighten it. If it straightens, you can do a soft tissue procedure. If not, you've got to do a bone procedure. Try and keep it as simple as possible. Okay? Soft tissue is pretty easy. In some cases, in certain candidates, you can do it with a needle. Okay? So a flexible hammer toe, you can release with a needle in some cases. So we'll do a flexor tendon lengthening and it'll pop out. Others that may have 1, 2, or 3, we do what are called PIP arthrodesis, okay, which is a fusion of the joint. If everybody held their finger up and bent that joint right there, we fuse that joint, this one. You say, why in the world would you do that? Because it'll come back. So the second toe, there's long-term studies done on if you take a piece of bone out, it's called an arthroplasty, and said walk around on it for 4 years, almost to the day, bonk, it comes right back. So we fuse the second and third toes, sometimes the fourth. Okay, and the reason we fuse it is, remember the muscle imbalances? It'll come right back. The same imbalance is there. We're not fixing the imbalance. So we fix the lever, the rigid lever. We fix the bone in there. So if we fix that hammer toe and pull it down straight and get those two bones to heal in there, then yeah, you can wave bye-bye, right? Like a kid. I can't do it, but you can't do that anymore with your toes. Well, when you walk, you don't do that anyways. So we can make the hammer toes go away with a little procedure then. You can, and there are different types and different ways to fixate that. So usually bone that we're trying to get fused, you have to fixate, and I'll go over that in a minute. When we assess also the hammer toes flexibility, rigidity, we also sometimes see them crossing over each other, right? 2 and 3 might be over 4. 4 might be on top of 3. 5's usually under 4, you know what I mean? So, and these are sagittal, plane, and different types of things we look at. So there's a lot to assess in there. The other thing is to check for instabilities. So is there a ligament that was torn? Did someone slip and fall? Did they slide off some stairs and hit their toe? Did it dislocate? Did it rupture the plantar volar plate? So what we see now is toes can actually bounce off of the joint from a rupture from long-term standing hammer toes, and they can rupture it, and the toe can actually come up like an elevator. It completely separates from the joint. Okay, so those are pretty sophisticated injuries, but they happen. They completely dislocate. You know, soft tissue transfers to hold the toes back in position, and then the degree of deformities, locations, all these angles and things we look at, how to get them to pull down and get them fused. And then we advanced on to, you know, the old methods were to, and they still are very effective in today's world, use wire. So when you fix a toe, you can stabilize them with a wire. Okay? So put a wire inside the toe. It sits on the outside of it and it's perfectly straight. So when we fix that joint, you can put the wire in the toe. 4 weeks later, pull it out and the toe's fused. Okay? The other methods in today's world, about 6 or 7 years ago, started new implantation for toe implants. So they started with the first line of what we call phalangeal implant, which just kind of, when you were doing the procedure, you put it in this side and you snapped it closed, and the toe would stay straight on that implant. And then there was the next line and the next line, and now there are 2-component snapping systems and locking systems and all that. So there are different ways. So there are the old methods and the new, and the reason for that is to keep them, you know, keep them from having to have pins in the tips of the toes. But there's still certain cases that you need to use them. I had a case yesterday I had to put 3 wires in. So we still use old methods and we still use a combination of new methods. That's it in a nutshell. If you guys have any further questions, fire away, and thank you.